Дорогие друзья, коллеги, глубоко уважаемые гости, дамы и господа, для меня высокая честь сегодня открыть наш первый вебинар, который посвящен проблеме атеросклероза и связанных с ним сердечно-сосудистых заболеваний. Я должен с удовольствием отметить, что этот вебинар стал возможным благодаря длительному, я бы сказал, плодотворному сотрудничеству Российского кардиологического общества с американской коллегией кардиологов, нашей общей нацеленности на выявление пациента высокого риска, нашей общей нацеленности на поиск новых методов профилактики и лечения всех заболеваний, которые связаны с атеросклерозом и с другими факторами риска. В нашем семинаре принимают участие выдающиеся кардиологи, которые связаны с Российским кардиологическим обществом, являются членами американской коллегии кардиологов. И я с удовольствием хочу передать слово моему соведущему, представителю американской коллегии кардиологии, доктору Памеле Моррис.
Здравствуйте, меня зовут Dr. Pamela Morris. I am very honored to be here today on behalf of the American College of Cardiology.
Представлять американскую коллегию кардиологии, поскольку мы ведем действительно революционную программу по профилактике сердечно-сосудистых заболеваний.
The president of the Russian Society of Cardiology and a great friend to the American College of Cardiology, Professor Evgeny Shlakto. We are so grateful for the warm welcome from you and our colleagues at the RSC and for your leadership throughout the planning process for today's webinar. We would not be here today without your team's incredible guidance and support. The ACC is also grateful for the support that Pfizer Inc. has provided for the attendance here today. I'm joined by two colleagues who you'll be meeting later on in the program, Dr. Salim Virani and Dr. Seth Martin, who are two of the foremost global experts in cardiovascular disease prevention strategies, and they will be leading two of the three presentations that are planned for our audience here today in St. Petersburg, as well as those of you who are joining us by live stream throughout Russia. My involvement with this program began just a little more than a year ago when I myself had the opportunity to present at a similar webinar which took place in China. Again, there were a total of 3 webinars focusing on different aspects of prevention: primary prevention, secondary prevention, and prevention in the patient with multiple risk factors. These programs, we look forward in 2017 to really replicating the success of the China program in at least 10 additional countries, including here, the first program in Russia under the guidance of the Russian Society of Cardiology. Now, we approach these webinars really in a spirit of partnership and really mutual cooperation with the local healthcare professionals, the policymakers in government, the local patients, and all of the other stakeholders here in Russia who are concerned with the increasing prevalence of cardiovascular disease. But at the same time, we approach these webinars with a real spirit of humility because we recognize that the United States has undergone and is still resolving many of the same challenges that you are facing among physicians, patients, and the healthcare system here in Russia. Through our experiences of tackling the problem of the increase in cardiovascular disease over the past 4 decades, We have accumulated a great deal of expertise in the field of prevention. What has worked, what has not worked, how far we have come, but really, in truth, how much farther we have to go. While we've made a great deal of progress in reversing the increase in cardiovascular disease in the U.S., we still have a great deal to learn and more room to grow. We hope that through these series of webinars that we can exchange some of our historical expertise with you and learn from you how your local physicians are addressing your country's unique challenges in cardiovascular disease prevention. We're very confident that through your attendance in this webinar, you will gain valuable insights into the latest strategies for preventing cardiovascular disease and in treating patients who are at high risk. We hope that you will be able to apply these insights and strategies in your practices and increase the tools that you have available to you to help your patients improve their risk status. Most importantly, we want to recognize that there really is no one single answer to preventing cardiovascular disease and reversing the global epidemic. What has served us best in the U.S. is a multifaceted approach that places not only emphasis on pharmacology and increased patient awareness of the importance of lifestyle management and the importance of risk factors such as smoking and obesity. Also, the importance of the interaction between the provider and their patients, and also the importance of input from multiple stakeholders, including government policymakers and the private sector. So in conclusion, let me repeat again what an honor it is to be here with you today, and that we all have the opportunity to participate in this program and cooperate with the local medical community and exchange best practices in cardiovascular disease prevention. So thank you so much. I wanted to take one moment to just mention to you that this session is designed to be very interactive. You will have the opportunity, each of the presenters will have a series of questions. Those of you in the live audience have your audience response clickers. Those of you who are joining us on the online audience, we'd like for you to click on the link to the questions so that you may also participate by voting online. In addition, many of you participated by taking a pre-assessment questionnaire, which has been very important to us in terms of understanding what the educational needs are of all the participants. There will also be a very important post-assessment questionnaire, which will be used to judge how effective we were in meeting the educational needs of the audience. And finally, at the end of the program, we will have time for questions and answers. That will be in a session reserved at the conclusion of all three presentations. And we encourage those of you online to submit your questions online. And those in the audience, we will be here in the live audience, we will be asking you to submit your questions here in person. So thank you again very much. I'd like to turn the podium over to for a moment to Lobna Salem, who is the Global Cardiovascular Medical Team Lead for Pfizer Inc., our sponsor of these programs. Thank you so much.
Thank you so much. Thank you, Dr. Evgeny Shilakto, for having us. Thank you, Dr. Pamela, for the introduction and for the collaboration. Thanks for everybody for attending either in the audience or online. On behalf of Pfizer Inc., it's our great pleasure and honor to be part of this educational collaboration between ACC and RSC. This collaboration, as you know, helps to decrease the cardiovascular burden in Russia. Pfizer has always had an unwavering commitment to decrease cardiovascular disease globally. Through our extensive clinical trial programs, we helped shape guidelines that led into aggressive confrontation of cardiovascular disease and helped change those guidelines. We are proud to have a very strong partnership with RSC that extended and will extend for decades to come in order to decrease the cardiovascular burden in Russia, as we are in Russia. Pfizer, I'd just like to spend a moment to explain how the partnership with ACC came along. We kicked off a global partnership with American College of Cardiology at a global level in the World Heart Day last September, after, like what Dr. Morris said, a successful pilot in China. And we leverage our mutual global reach and local footprint in this partnership. This partnership is very unique. It's not just an education, which is very respected, of course, to have an educational. It's what we call purposeful education, with the objective to improve the uptake of local guidelines that ultimately will improve patient care. So I'm really, this is the first of the 3 webinars, as Dr. Morris alluded to, and after the successful pilot in China, we're happy that as a global partnership, we're extending this partnership to multiple countries: United Arab Emirates, Egypt, Saudi, Indonesia, for the 2nd year in China, Indonesia, Mexico, Argentina, Malaysia, and Vietnam. We are optimistic that this global and local collaboration will achieve its intended outcome, i.e., to improve the patient outcome, hopefully in Russia and globally. With that said, I'd like to hand it over back to Dr. Morris, and thank you so much.
Thank you so much, Lobna. Well, now with the introductions concluded, I'd like to introduce our first speaker. This is my esteemed colleague, Dr. Salim Varani.
Thank you, Dr. Morris. Thank you, Professor Shlakto. Thanks for the opportunity to be here. So what I'm going to talk about in the next 25 to 30 minutes is risk factor burden and risk assessment in cardiovascular disease. These are my sources of research support as well as disclosures. So what we would like to achieve in the next 25 minutes or so is to first understand the importance of multiple risk factors when it comes to cardiovascular disease. Why is it important to perform risk assessment in cardiovascular disease? And then what are some of the risk assessment tools that we have available that we can use on our patients so we can improve risk assessment? And then last but not the least, how do we make our patients part of this risk discussion as well as implementation of the guidelines in the most efficient manner? So let's talk a little bit about the burden of cardiovascular disease. Professor Shlakto is going to get into the details of this, but I'll just give you a few numbers to catch your attention. All over the world, every year, almost 18 million people die from cardiovascular disease. Just to put these numbers in perspective, if we say we have 196 countries, 18 million, if you look at that number, 2/3 of the world countries have a population less than 18 million. A country like Syria has a population of 18 million. That's the number of people who die every year from cardiovascular disease. If we look at the number of people dying from cardiovascular disease, the mortality has actually gone up by almost 12.5% in the last 1 decade. If you break it up, the mortality from strokes has gone down, but the mortality from myocardial infarction, heart attacks, has actually gone up. Now, that could be due to very many reasons. If we look at low and middle income countries, a lot of that is dependent on traditional risk factors, whereas if you look at countries that have done materially very well, a lot of that is because of the aging population as well as the rising epidemic of obesity. These are some data from Russia where you look at the NCDs, and obviously as you may know, NCD is a very broad term that includes very many diseases, including cardiovascular disease. These are data from WHO for 2014 showing that in Russia, 85% of the deaths in year 2014 were caused by non-communicable diseases. And the 4 biggest players in these non-communicable diseases include cardiovascular disease, which is the largest NCD, cancer, cardiorespiratory diseases, and diabetes. The reason I show this here is very important, that when we are treating cardiovascular disease risk factors, we are not just taking care of cardiovascular disease, because all these NCDs share common risk factors. If we take care of smoking in our patient with cardiovascular disease, guess what? The prevalence and the incidence of cancer also goes down. If we treat obesity, cardiovascular disease goes down, and diabetes goes down. That's why by treating cardiovascular disease risk factors, we are not just bringing down the prevalence and the incidence of cardiovascular disease, but we're actually working on a lot of these NCDs, non-communicable diseases, which lead to most deaths in Russia and all over the world. Now, if you look at the cardiovascular disease mortality in US, you'll see that great progress has been made. And, in the last few years, we actually had a downturn, which now seems to have plateaued. A lot of that is because of better control of risk factor, better risk assessment tools available to physicians as well as other healthcare providers. But now we see that this has plateaued. In US, a lot of that is probably related to obesity. And even if you look at the data for Russia, after great progress that has been made, these numbers seem to have plateaued now. So what is it that has led to this decrease in cardiovascular disease mortality in the US? In US, it's been due to decrease in cigarette smoking, decrease in secondhand smoke, reduction in blood pressure, reduction in cholesterol, as well as improvement in cardiovascular risk assessment, whereby you know which patient I have to treat and with what therapies. So let's talk about primary prevention of cardiovascular disease. What is the importance of multiple risk factors? So here's the data from a very widely quoted study called InterHeart study, which was one of the largest studies looking at the determinants of first myocardial infarction performed in 52 countries, almost 15,000 cases and 15,000 controls of individuals who had their first myocardial infarction. What you see on this slide is something to worry about, that we have so many risk factors, but something that is very comforting as well, that more than 90% of the population attributable risk of MI is actually dependent on 9 reversible risk factors, whether it is lipids, psychosocial risk factors, smoking, diabetes, obesity, hypertension. So what we're trying to convey the message here is that this global epidemic of cardiovascular disease is very much under our control and the control of our patients, as long as these risk factors are identified and properly treated. And that is where this concept of ABCDE is important. Very easy to remember. A, assess risk in a patient using risk assessment tools that we have. Antiplatelet therapy, aspirin if patient is a candidate for antiplatelet therapy. Blood pressure control, cholesterol control, cigarette smoking cessation, diet and weight management, diabetes management, and E for exercise, one of the most important reasons. Do not forget, today we're going to talk a lot about risk assessment and cholesterol, but don't forget your exercise. Just to give you some numbers, if somebody walks 75 minutes per week, on average, that person lives about 1.8 years longer. Those who are active and non-obese, on average, live 7.8 years longer than those who are obese and inactive. So very important messages that we need to talk to our patients about in addition to other risk factors. And therefore, the intensity of preventive efforts should be calibrated to the absolute risk, and I'll come to that in a minute as to why that's important. The other aspect of this is to understand that risk starts early. So these are patients, these are data from Framingham study. If you follow patients at the age of 50 and look at multiple risk factors at age 50, if every risk factor is optimal in men or in women, you see they have very low risk of dying from cardiovascular disease over the next 30, 40 years of follow-up. On the other hand, even if you have two major risk factors, diabetes, hypertension, obesity, high cholesterol, you have almost 70% risk of dying from a heart attack. So this is a very important message that it's actually very important to start early as we can. Now, the other important message here is, first is that we need to control the risk factors. The second thing is that we as healthcare providers should get into the habit of not just counting someone's risk factors, but actually performing a risk assessment. And why is that very important? Look at this female who's 60 years old and has a cholesterol of 7 millimoles per liter, systolic blood pressure 120, not a smoker. If you do 10-year risk calculation using SCORE algorithm, which is what's mostly used here in Russia, her risk, future risk, 10-year risk of dying from a heart attack or stroke is 2%. If you make that person's blood pressure go up a little bit from 120 to 140, and if that person starts smoking, it goes up to 5%. Almost 2.5-fold increase in their 10-year risk of dying from a heart attack or stroke. Now, counting risk factors is important, but you will not be able to put it in a number and explain to the patient. That is why it's extremely important to look at each individual risk factors, but put all those risk factors into a risk assessment algorithm and then come up with a number that you can communicate with your patient. This is another reason why we should perform risk calculation and not just look at each individual risk factors. It is good to target each individual risk factors when you're treating a patient, but when you're assessing risk in a patient, it's important to put all those risk factors into a risk assessment calculator. Look at this data from statin trials. As you would expect, the more you reduce LDL cholesterol, the more benefit you get. But look at this particular group. Even when you have the most reduction in LDL cholesterol and most reduction in events, those who derive the most benefit from statin therapy are the ones who are at the highest risk of events. In this case, more than 30% 5-year risk of having a cardiovascular event. If you did not know this, you would not know which patient is going to actually benefit the most from statin therapy. So that's why it is extremely important to perform risk assessment. So just to summarize what we've discussed thus far, the principle of risk assessment, the first goal is to identify patients who are most likely to benefit from primary prevention. Global risk assessment tools, whereby we put these into a risk calculator, can identify patients who are at low, intermediate, and high risk. And then we focus on those who are at moderate to high risk, kind of population-based approach to treating cardiovascular disease. And although the relative risk reduction is the same, we get the most bang for our buck. Absolute risk reduction is the highest for those who have the highest risk of having an event. So then the next question is that how do we do this global cardiovascular risk assessment in our patients? So before we do that, let's do a question to see what you all use. Again, for our audience here in the hall, if you can just use the clickers you have, and those who are using the live stream, if you can just click on the link you have to answer this question. So our question is, which risk assessment tool do you currently use in your practice? Do you use the Framingham Coronary Heart Disease Risk Score? Do you use the ACC AHA 10-year pool cohort risk calculator? Do you use SCORE or the Systemic Coronary Risk Evaluation, or none of the above? Let's see if you can answer that, and then we'll discuss the answer. We'll wait till we have all the responses. This means nobody responded. Just kidding. Okay. So it seems like most of our audience who are here, the live audience, use SCORE for risk assessment. Let's see what we have for our audience that's attending the webinar. And again, there again we see that SCORE is the most commonly used risk assessment tool. And that's what we would expect based on the European guidelines that are being used here. Okay. So let's see how do we assess risk when we are seeing a patient. And since most of you use SCORE, I will spend a little bit of time on that risk assessment algorithm. All right. So when we are looking at SCORE risk assessment algorithm, first of all, it's important to know what are the things that we are putting into the risk calculation. Obviously, we need to know a person's gender. We need to know whether they're smoker or non-smoker, their age, their systolic blood pressure, and their cholesterol. Once you have those numbers, you plug into either a low-risk chart or a high-risk chart. For Russia, you would put high-risk chart, or you will use the high-risk chart. So this is a high-risk chart that you can use in a Russian patient. So I will do an example with you towards the end of this presentation, but one of the most important things I want to identify based on our assessments that all of you did, and thank you for doing it, is to understand what are you actually measuring. So remember, what we're measuring by using SCORE algorithm is 10-year risk of fatal atherosclerotic cardiovascular event. Somebody dying from myocardial infarction, stroke, or other occlusive disease, including sudden cardiac death. So if somebody has a heart attack but does not die of it, that is not what you will pick up on the SCORE algorithm. So make sure you understand that when we're using SCORE algorithm, we are picking up events that are fatal events. Somebody dying from heart attack or stroke, which is different from some of the other risk calculators that we'll talk about. So let's move on to the second most widely used risk calculator, which is the American College of Cardiology, American Heart Association, ACC-AHA, atherosclerotic cardiovascular disease risk estimator. Again, we plug in total cholesterol, HDL cholesterol, systolic blood pressure, medications for blood pressure, diabetes, and smoking, and you get a 10-year risk. But in this case, the 10-year risk includes both fatal as well as non-fatal events. So somebody dying from a heart attack or stroke, but in addition, somebody who has a non-fatal myocardial infarction or non-fatal ischemic stroke, those patients will also be picked up. So important to know the differences when you're looking at different risk calculators. Now remember, this is intended to be used for patients between the ages of 40 and 75 years. And again, I will show that to you in a summary slide one more time. Now, the one that used to be used quite often, but we don't use it as often now, is the Framingham coronary heart disease risk score, which was recommended by the prior set of guidelines in US, the ATP3 guidelines. And there again, the inputs are fairly similar, but what we're calculating is a 10-year risk of myocardial infarction or 10-year risk of dying from coronary heart disease. So what you will see missing here is having ischemic stroke or dying from ischemic stroke, which was not part of this Framingham CHD risk calculator, but the new ACC-AHA risk calculator that I showed you on the prior slide actually includes those events as well. Now, All of these risk calculators that we have are used for risk assessment at one point in time. When we're seeing a patient, you do the risk calculation, but you cannot use it on a longitudinal basis. So there was a recent risk calculator that was worked out between investigators from both ACC and AHA, whereby they looked at how can we start someone on one therapy and then follow their risk on a longitudinal basis. And then how about if we start aspirin therapy, if we bring blood pressure down, if we control cholesterol, if we control smoking? Well, using any general risk calculator, you cannot account for all of those. So there is a longitudinal risk calculator available now, which is known as a Million Hearts Longitudinal ASCVD Risk Assessment Tool. It just came out a few months back. So any of you who are interested in doing longitudinal follow-up of patients, whereby they make one change, let's say the patient says, today I want to just control my blood pressure. I don't want to start statin therapy today. Or I don't want to start aspirin today. I do not want to cut down on my smoking today, but maybe next time I'll do that. Well, in that case, having this longitudinal risk calculator is actually very good. So just keep it at the back of your mind that there is something available now whereby even longitudinally we can follow our patients. Now, this is a slide where I'd like to have some attention from you because this summarizes a lot of things that we've discussed in terms of risk calculators and also identifies some areas that we thought we would like to emphasize based on the pre-assessment we did. Let's focus first on the SCORE cardiovascular risk assessment tool. Remember, what goes into it is age, sex, total cholesterol, smoking, blood pressure, and what it gives you as the outcome is 10-year risk of fatal cardiovascular events. People dying from heart attacks or strokes is what you're going to calculate. If you look at the ACC-AHA risk estimation tool, very similar variables, but in addition you have HDL cholesterol, treatment for hypertension as well as diabetes. Remember, LDL cholesterol is not part of this risk calculator. There was a question on your pre-assessment whereby we thought some people got confused a little bit. It's the HDL cholesterol that's there. And what this risk calculator calculates for you is 10-year risk of both fatal as well as non-fatal cardiovascular events. Now, the Framingham CHD risk calculator gives you a 10-year risk of MI or CHD-related death. Remember, it does not give you anything related to ischemic stroke, which is an important outcome. So the most important message out of this slide is that as far as SCORE is concerned, it measures 10-year risk of fatal cardiovascular events, whereas if you're using the ACC-AHA 10-year risk calculation, then you're calculating a 10-year risk of fatal as well as non-fatal cardiovascular events. So let's do one more question, and again for our audience here, if you can use your clicker, and for our online audience, if you can click on the link to the question and answer this, we would appreciate. So which one of the following variables is not included in Framingham, SCORE, or the 2013 ACC-AHA pool cohort risk equation? Is it sex? Is it total cholesterol, age, family history of premature cardiovascular disease, or systolic blood pressure? You can start your answers and voting now. So for our live audience, perfect, good job. You all got it. Let's see how it is for our online audience. And we have the same kind of response there. Most of the people got the right answer. So remember, when we're using most of these risk calculators, family history of premature cardiovascular disease is not a parameter that we put in that equation. And why is that important? If you get a 45-year-old male who comes to your clinic and says that my dad passed away from myocardial infarction at the age of 48, and you do a risk calculator, or you use any risk calculator, and they have low risk on that, does that mean that you do not treat that patient early? No. So this is a limitation of all the risk calculators that we currently use, SCORE as well as the 2013 ACC risk calculator. So it's very important to understand what are the limitations. So let's talk about the limitations of these ASCVD risk calculators. Remember, as we discussed, not all include family history of cardiovascular disease. So if you have a patient who has history of premature cardiovascular disease, then use your judgment. It does not mean that we withhold therapy in those patients. And remember the risk of other cardiovascular events. Heart failure related hospitalizations or events are not measured by the risk calculators that we just talked about. They may not accurately assess risk in all ethnic groups. The biggest issues we face living in US are what do we do with our Hispanic patients? What do we do with our South Asian patients? In Hispanic patients, sometimes our risk is overestimated. In some, it is underestimated. And remember, most of these are based on risk factors that are assessed at single point in time. You cannot use them repeatedly once you started somebody on a therapy, except the longitudinal risk calculator that we talked about, which is the Million Hearts risk estimator. And then not all have been validated in clinical use. For example, the Million Hearts tool that I talked about has not been validated for clinical use yet. It is there, it has been tested in multiple patients, but we don't have a study whereby it's been done in millions of patients. On the other hand, when you look at the ACC-AHA risk calculator or the SCORE CVD risk calculator, it has obviously been verified in multiple populations. And remember, this is the most important thing. When there is uncertainty about risk assessment in a patient, at the end of the day, these are risk estimators. A lot of people will not use the word calculator because these are not very precise. If you think a patient is at a higher risk, then use your judgment. For example, the patient we talked about with premature family history of cardiovascular disease, or if you need to, use an imaging test for further risk stratification. So how do we put all of this, what we have discussed in the last 25 minutes, into practice? Well, the first question you will ask me is, what age do we start using risk assessment? And if we focus on just the SCORE risk assessment, which is what most of you are using, then the guidelines from European Society of Cardiology would say that we start doing risk calculation in men above the age of 40 and women above the age of 50. Okay, if you are to use ACC-AHA risk calculator, then it goes from 40 to 79 years of age. So remember, 40 for men, 50 for women. Now let's do a case and see if we can figure out what is this patient's 10-year risk of having a fatal cardiovascular event. So we have a 60-year-old patient that you're seeing in your clinic. It's a male, smokes, has a systolic blood pressure of 160, total cholesterol of 5 millimoles per liter. Now let's see if we can figure out what is this person's 10-year risk of cardiovascular event using SCORE criteria. And as I said, for Russia, we use the high-risk chart. So we have a 60-year-old male. So he's going to be in one of these two boxes. He's a smoker, so we'll use this box. And then his cholesterol is 5 millimoles per liter. So we go here, systolic blood pressure of 160. So this person's 10-year risk is 14%. Now, what is that risk? Remember, this is 10-year risk of having a fatal cardiovascular event, dying from a heart attack or a stroke. Is it high risk, low risk, intermediate risk? By the guidelines, this would be very high risk. Okay, 5 to 10% is high risk, 5% is the cutoff where you can start thinking of treatment, so that's high, 5 to 10%, and anything more than 10% using SCORE criteria is very high risk. Remember, this is fatal events, not just having an MI or a stroke, dying from one. So my question to you here would be, how will you treat this patient? Will you start a statin on this patient? Will you ask him to stop smoking? Will you treat the blood pressure today? Will you do all of them? How many of you will start with a statin, just by show of hands? Okay. How many will just treat blood pressure today? Yeah. And how many will ask the patient to stop smoking? How many of you will try to do all three of them today? A lot of you, very aggressive group. So that's good. So here is where we need to basically do this risk calculation, and then this is where it becomes extremely important that, remember, guidelines are guidelines. You implement them in clinical practice, but at the end of the day, the patient decides what they want. Our job is to explain it to the patient. So how do we explain it to our patients? The first thing is that we explain it to the patient in a way that the patient understands. If I say to a patient, you have 14% chance of dying from a heart attack or stroke over the next 10 years, that's difficult. The way we should present that information is that if I had 100 patients like you, in the next 10 years, 14 out of those 100 patients will die of a heart attack or a stroke. That makes it much easier for the patient to understand. Present this number to the patient. When you give them objective data, they understand better and they're more likely to adhere to the treatment that we prescribe them. Understand what is patient's perception, what would they like to do? We are talking about a statin, but they might be more interested in trying to quit smoking, which is as important as starting a statin. So ask the patient what would they like to do, and then we come to a consensus. If the patient says, I want to start a statin, you can use visual aids, that if 100 patients took statins for 5 years, then 40 of them will not have a heart attack or a stroke over the next 10 years. So use visual aids, use language that is easy for our patients to understand. So to summarize, how is this shared decision making performed? And you will hear some more of this in the next talk as well. First, we ask the patient, what do they perceive as their risk? What do they think is the most important thing for them when it comes to these risk factors? What is the cost for the patient? Then we look at the evidence that is there, what we know. What we know are the guidelines that tell us what to do. We put both of those together. We provide benefits and risks of the therapies to our patients. We discuss what are the alternatives to therapy. Is diet and lifestyle a better option, which may be in some patients? What are the strategies to minimize the risk? And then we come to a decision using decision aids when available, language that is simple and easy for our patients to understand, and monitor adherence. Just starting a statin or starting a blood pressure medication is not enough. We need to make sure that our patients are actually adhering to those recommendations and medications that we're talking about. And last but not the least, do not forget that risk assessment and discussion with the patient is not a one-time deal. We just don't do it once and stop. It can be repeated over and over again to emphasize why it is important for our patients to control their risk. So to summarize what we have discussed thus far is that comprehensive risk factor reduction is key to cardiovascular disease prevention. It's not just one risk factor. We have to work on multiple risk factors. Intensity of preventive efforts, whichever treatment we use, should be calibrated to absolute cardiovascular risk in our patient. And the way we do that is by using risk calculator, not just counting the number of risk factors. Therefore, risk scores serve as a useful tool to open the door for discussion with our patients about risks and discussion regarding plans for risk reduction. And remember, a risk reduction for cardiovascular disease and that discussion should occur on an ongoing basis. It is not a one-time deal. It happens on a routine basis, ongoing basis, and this should be done to encourage patient adherence to medications, and do not forget the lifestyle recommendations, which are as important as prescribing medications to our patients. Thank you for your time.
Great. Well, thank you so much, Dr. Virani, for that excellent discussion. And now it is again my privilege to introduce you to our next speaker, Professor Slachto.
Дорогие коллеги, моя задача представить вам сообщение о распространенности и структуре факторов риска сердечно-сосудистых заболеваний в Российской Федерации. У меня нет конфликта интересов, и в рамках своего доклада я остановлюсь на трех главных позициях. Это тому состоянию, где мы сегодня находимся, какова заболеваемость в России, проблемы достижения последних лет. Далее мы рассмотрим вопросы нашей стратегии в отношении профилактики сердечно-сосудистых заболеваний и роли кардиологического общества, и о том, что ждет нас в следующем десятилетии. Я должен сказать, что за последние годы в России сделано очень много для того, чтобы решать проблему высокой заболеваемости и смертности от сердечно-сосудистых заболеваний. Если вы посмотрите на этот график, то есть по меньшей мере два пика, когда заболеваемость по основным классам заболеваний, в том числе сердечно-сосудистые заболевания, резко возрастали. Это начало 90-х годов, и это начало 2000-х годов, когда эти пики значительно увеличились. Связаны они, безусловно, с теми временными параметрами, когда мы жили в это время, это в основном выпала участь на кризисы, экономический кризис, начало 90-х годов, политический кризис. Безусловно, это все влияло на высокую смертность. Но начиная с 2004-2005 года ситуация стала меняться. Была сформирована стратегия борьбы с этими заболеваниями, и государство стало уделять пристальное внимание. В качестве примера я коснусь, что прошлый год у нас был годом борьбы с сердечно-сосудистыми заболеваниями. И видите, что кривые сердечно-сосудистости, и особенно кривая смертности от внешних причин, постепенно в течение последних лет снижается. Нужно сказать, что если посмотреть все регионы Российской Федерации, то практически везде наблюдается положительный тренд в отношении снижения смертности от всех причин и смертности от сердечно-сосудистых заболеваний. И эти тренды, они идут, как видите, параллельно, что тоже очень важно практически по всем округам и практически всем субъектам Федерации. Хотя нужно сказать, что проблема сердечно-сосудистых заболеваний остается большой, и в смертности по-прежнему вклад именно смертности от сердечно-сосудистых заболеваний практически по всем округам остается очень высоким. Нужно сказать, что благодаря тем позитивным изменениям смертности, которые наблюдаются в последние годы, мы видим увеличение ожидаемой продолжительности жизни при рождении в России. Эта величина перевалила уже не только у женщин, но и у мужчин 70 лет. Безусловно, эти тенденции, так же, как в общем и в других странах, в ближайшее время приведут к изменению демографической ситуации, к изменению соотношения лиц молодого, среднего, пожилого возраста. Это не пирамида, это уже не колокол. Мы близки и движемся в сторону цилиндра, когда доля лиц, возрастных лиц среднего пожилого возраста будет нарастать. Это, безусловно, та ситуация, которая уже завтра будет определять
And this is the situation which is going to determine, starting from tomorrow, our future strategy of controlling heart condition and the overall strategy of healthcare providing throughout the Russian Federation. We will certainly see greater morbidity linked to age. We will see fewer cases of CVD, because now we have achieved quite a lot in treatment of IM and other coronary diseases, as well as of degenerative modifications of the heart apparatus. This is certainly going to determine our future demographic situation. Over the recent years, Russia has paid close attention to epidemiology. We have a good experience, a very positive experience of taking part in many large-scale projects globally, such as MONICA, for example. We've taken part in studies supported by the government and by the World Bank. We do remember a large-scale program of prevention and treatment of AH, which was supported by the Ministry of Health. And we had quite a number of initiatives, such as NICA study, epidemiology of metabolic syndrome, for example, which took place in the last decade. Another important study is ESSE-RF, which stands for Russian Federation. 22,000 persons were examined throughout the country. So we see that the coverage of this study is quite extensive, and we followed all the rules and guidelines regulating those types of studies. We used standard methods such as screening, where we measured blood pressure, heart rate. We also took a look on the values linked to lipids, glucose, uric acid, creatinine. We did genetic screening, and at the last stage, it was an extended examination involving other parameters that are mentioned in this chart. So my presentation is going to focus on those data that are a baseline, a starting point for us, and that show our current standing in Russia in terms of the prevalence of main risk factors. If we take a look on the prevalence
и контроль артериального давления, то мы видим, что действительно в разных регионах эти показатели довольно сильно различаются от 20% в южных регионах Владикавказа до почти 40-50% в центральной части Российской Федерации, Воронеж. В целом это чуть меньше 40%. То же самое можно говорить о большом разбросе в отношении контроля, лечения артериальной гипертензии. Мы видим, что эти параметры, если сравнивать с предыдущими десятилетиями, значительно выросли. Более 50%, около 60% получают терапию, и мы видим, что в ряде регионов до 30-40% контролируется артериальное давление. Очень важно, что, безусловно, очень выросла осведомленность об уровне артериального давления в российской популяции, как среди населения. В целом российских регионах вы видите, что практически, если говорить о женщинах, то это около 90%, и более 70% у мужчин. И то же самое можно говорить о осведомленности артериальной гипертензии в связи с нормальным артериальным давлением и с артериальной гипертензией. Параметры где-то близки, что говорит о том, что жители Российской Федерации действительно стали обращать внимание на свое здоровье. Это, безусловно, результат тех программ, которые были выполнены под руководством Министерства здравоохранения в Российской Федерации, связанные именно с диспансеризацией. Нужно сказать, что детерминанты как систолического, так и диастолического артериального давления, они практически одинаковые. Это возраст, пол, региональная принадлежность в известной степени, индекс массы тела, окружность талии. И мы видим, что такой параметр, как возраст, безусловно, оказывает очень существенное влияние на эти показатели. Разница 14 миллиметров между возрастными группами 25-30 лет и 50-65 лет для систолического, 7,5 миллиметров для такой же возрастной группы для диастолического артериального давления. Безусловно, Российская Федерация, она не изолирована. Мы видим такие же тренды, как в мире, в отношении распространенности ожирения. Безусловно, вот на эти параметры сыграл переход на другие критерии оценки. Ожирение по окружности талия более жестким критерием 94 на 80. Мы видим, что практически на 25-30% увеличилось число пациентов как среди мужчин, так и женщин. Безусловно, мы задаем, так же, как и другие исследователи, вопрос, насколько это оправдано для будущей стратегии, и был ли настолько же параллельным увеличение показателей риска, отдаленного риска для этих пациентов, как сам по себе факт увеличения распространенности ожирения. В этой части мы проводим исследования НИИ, о котором я говорил, может, мы в ближайшие годы получим в известной степени какие-то ответы на эти вопросы. Довольно интересными данными являются распространенность курения среди российских мужчин и женщин. Мы всегда много говорили о том, что в общем, курение является довольно выраженным фактором риска в Российской Федерации, широко распространенным. И если мы посмотрим, что произошло за последние 10 лет, и сравним данные ВОЗа, Росстата 5 года, 2011 года и наши данные 2013 года, то мы можем уверенно говорить о том, что ситуация значительно улучшается, уменьшается распространенность курения как среди мужчин и в целом, так, если по сравнению с 2005 годом, и среди женщин почти на 50%. И больше. Безусловно, это связано с теми организационными мерами, которые были приняты последние годы. Мы имеем, я бы сказал, один из самых жестких антитабачных законов. Я думаю, что это такой очень важный фактор, который сам по себе будет влиять и на другие, связанные с этим фактором, обстоятельства, и в будущем мы будем иметь более позитивное движение в этом направлении. То же самое я хотел бы коснуться употребления алкоголя в Российской Федерации. Мы, безусловно, видим, что число людей, которые злоупотребляют алкоголем, оно невелико, причем в основном это умеренно употребляющие люди. Довольно высокий процент среди женщин, это более 20%, которые вообще не употребляют алкоголь. Это тоже, в общем, позитивный фактор. Я думаю, что этот фактор тоже в известной степени будет меняться параллельно с таким фактором, как и курение. Нужно сказать, что, безусловно, наиболее часто употребляющие лица – это молодого возраста. Если вы говорите о мужчинах, то же самое можно говорить о женщинах, но такой большой разницы в отношении малоумеренно злоупотребляющих, связанных с полным возрастом, мы не наблюдали. Что совсем приятно, оказалось, что Россия не так уж, если сравнивать с нашими ближайшими соседями, не так много употребляет алкоголя, меняется структура потребления алкоголя, уменьшается потребление крепких напитков. В основном мы сегодня имеем тенденцию к увеличению числа употребления слабоалкогольных напитков. Мы видим, что по сравнению с нашими соседями, особенно среди женщин, мы, в общем, выглядим очень практически совсем мало употребляющей алкоголь страной. К сожалению, сохраняется высокая распространенность избыточного употребления поваренной соли. Это в целом, если говорить по всем регионам, больше 40%. Распространенность избыточное потребление поваренной соли в ряде регионов мы видим большую распространенность, особенно мужчин, что, безусловно, связано с диетическими пристрастиями, я думаю, с особенностями того ассортимента пищевых продуктов, которые они употребляют, рыбные, что, безусловно, влечет за собой большее потребление поваренной соли. Ну и если посмотреть распространенность других факторов, которые влияют на риск, то мы можем сказать, что в целом, как среди мужчин, так и женщин, видите, преобладает абдоминальное ожирение.
The most important factors are abdominal obesity,
процент среди мужчин,
as well as
лиц, у которых есть повышение мочевой кислоты, вклад числа
uric
сердечных
acid
сокращений, уровень C-реактивного белка превышает 20%. Все это говорит о том, что довольно есть комбинация разных
It means
факторов.
that we usually deal with a combination of different
Неожиданно
factors.
уровень глюкозы больше 7 оказался не очень высокий,
The glucose
меньше 5%.
Over 7%
И в этой ситуации,
is
конечно,
only observed in
мы
7 in
встаем часто вопрос
less
нашей
than 7%
клинической
of the
практики
population.
для того, чтобы
In our clinical practice,
формировать стратегию в отношении
we
того или
usually
конкретного
think about how
пациента, того или
to
иного
shape up a
пациента,
strategy
какой
dealing with a
риск,
specific patient.
как мы видели в предыдущем сообщении, в
which
основном мы используем шкалу SCORE,
type of risk
и
we
для
can
нас, безусловно,
identify.
я чуть позже буду
Mostly
говорить, очень важным
we
является
use the
стратегия в
SCORE
отношении
scale
первичной, стратегия
in order
высокого
to
риска или
define our
стратегия борьбы, стратегия профилактики.
of
Для
prevention
этого нам, безусловно,
tackling
нужно сформировать свое представление, к чему
identified
относится
conditions.
больной. Является он
In
пациентом
order to
высокого
do
или
this,
очень высокого
we need
риска,
to-
или это пациент умеренного риска. От этого,
to
безусловно,
understand the
будет
risk
зависеть
profile of the patient,
объем
whether
и
he or she
стратегия,
belongs
и,
to a high
может
risk
быть,
group, to
характер
a
той
moderate risk group,
терапии,
or to a
которую
low risk
мы будем
group.
проводить. Поэтому,
It will
пожалуйста,
determine
просьба,
the therapy
какие из
that
перечисленных пациентов
we
являются
are going
пациентами
to
высокого и
prescribe.
очень высокого
So
риска,
please tell me,
пациенты с подтвержденной
answer
ИБС,
the question,
пациенты с
which of
артериальной
the following
гипертензией
patients are the
третьей
high
степени,
and very high
пациенты с
risk
сахарным
patients,
диабетом,
patients with documented
пациенты с
CAD,
хронической болезнью почек,
AH3
либо
patients,
все
diabetes
перечисленные
mellitus
группы
patients,
пациентов относятся к
CKD
высокому
patients, or
риску.
all of the above. Which group belongs to high and very high risk?
Ну, результат говорит сам
Well,
за себя
the result
и подтверждает высокий
very
уровень
correct.
нашей аудитории.
It
Безусловно,
confirms
ответ 5. Все
very
перечисленные
high
группы
awareness rate
пациентов
of
относятся
our present
к категории
audience.
высокого
Certainly,
риска.
all the
Я
5
специально
factors
задал этот
belong
вопрос
to the
перед
high
тем,
risk
чтобы
class.
как показать
I
вам
usually ask this
степень
question
риска по данным
before showing
исследования
you
ЕССЕ в Российской
the risk
Федерации.
level
И мы видим,
according
что
to
частота
ESSE
высокого риска, к
study in the Russian
сожалению,
Federation.
она
We
довольно
can see here
высока,
that
особенно у мужчин.
high risk
Это
patients are quite numerous,
40%
unfortunately.
обследованных лиц
40%
относятся к
of
категории
examined
высокого
male patients
риска.
usually
Средний
belong
уровень
to
риска
the high risk
также
group.
преобладает у
Moderate
мужчин.
risk
Безусловно, вот эти
is quite
данные в
prevalent
известной
in
степени
males,
накладывают
and those data
отпечаток на те мероприятия,
usually
которые мы должны
influence the
формировать
set of
в отношении
efforts, the
ближайшей
set of measures
перспективы
that
и в отношении
we
отдаленной
need to
перспективы. Мы видим,
adopt
что, безусловно, высокий
in
риск в
future.
большей степени
We
нарастает с
see
возрастом.
that the high
В
risk
группе
is increasing
45-54%
with age.
года таких больных
In the group of
почти в 2 раза
45
больше,
to 54,
чем среди лиц до 45 лет. И,
there are
безусловно,
twofold
еще
the
большее
number of
число мужчин
those
и
patients
женщин,
is twofold
имеющих
as compared
высокий
to the
риск,
previous
относятся
group,
к возрастной группе старше
and an even
55
higher risk
лет. Безусловно,
is associated to the next group
наличие высокого, очень высокого риска
over
предполагает,
55
безусловно,
years. Certainly, the presence of a
череду,
high risk
объем профилактических
involves a
мероприятий,
set of
которые включают
preventive
как изменение
measures
образа
of
жизни, так и назначение
preventive
различных классов, если говорить о
efforts,
антигипертензивных
as well as
препаратах,
prescription of different
различных классов
medicine.
лекарственных
For
средств.
example,
И мы видим, что мы имеем
antihypertensive
довольно
drugs.
высокую частоту
Here we
назначения
see that
ингибиторов ангиотензин превращающие ферменты. Если посмотреть вместе с
angiotensin enzyme
рецептора ангиотензина 2,
inhibitors
то
are
это
very
почти
often
около
prescribed
80%
in
назначается,
almost
довольно высокий процент,
80% of cases,
35% бета-блокаторы,
then
треть
35%
диуретики и
beta blockers,
14% проценту
The
антагонисты
next one is
кальция. Это, в
diuretics
общем,
and
тот
calcium antagonists
процент лекарственных
for the next
препаратов,
group.
близкий к тому,
This
что
is the percentage
назначается
of
в целом в
drugs and
Европе. Второй части
medicines which
доклада
is
я хотел
close
коснуться
to
той
current rates in
стратегии,
Europe.
которая сегодня
In the second
рассматривается в
part of my
Российской Федерации в
presentation, I'd
отношении
like to tackle
профилактики
to discuss the
сердечно-сосудистых
strategy of the
заболеваний.
Russian
Я уже говорил,
Federation
что
in
мы
terms of heart disease
участвовали
prevention.
и имели программу борьбы,
I
государственную
said that
программу
we
борьбы с артериальной
had
гипертензией
taken
в
part in different state
2009-2013
organized
году,
programs
которая была в
of combating
известной
arterial
степени частью
hypertension. It
национального
was in
проекта здоровья
2009
и
and
имела, безусловно,
2013
крайне
as
важное
part of the
значение для
national
повышения
project
осведомленности
It was
об
a very
артериальной
important
гипертензии, для
step in order to
повышения
raise awareness about
частоты назначения лекарственных
age,
препаратов, для
about
повышения
the
приверженности
drug prescription,
приема лекарственных
about
препаратов.
increasing
Большое значение сыграл
patients'
2015
adherence.
год, который был объявлен президентом годом борьбы с
2015 was a landmark
сердечно-сосудистыми
year
заболеваниями, в
because
рамках которого
the
мы
president proclaimed
получили
it
и
the
данные
year
о том,
of
что не только
combating
первичная, но и
CCDs.
стратегия высокого
That's the
риска
year that
должна
we gathered
быть
data about
важной составной
high
частью,
risk and
и
medium
особенно
risk
эти данные, которые я
prevention
показывал
strategies,
о высоком риске среди
basing
мужчин
on the
почти
data
40%.
on high
И,
risk
наконец,
among
я
males
хотел
that I've
бы
showed to
поделиться
you.
с вами нашими
And
проектами
finally,
в
I'd like to
отношении
share with you
участия
some
Санкт-Петербурга в
information
программе
about
«Здоровые
our
города»
project,
и
about the participation of St. Petersburg in
тех
the program called
ожиданиях,
Healthy
которые мы
Cities,
связываем
about
с
the
реализацией этого
expectations
проекта.
that are linked to the
Безусловно,
implementation of this
первичная
project.
профилактика – это
Of course, primary
краеугольный
prevention
камень борьбы
is
с
a
сердечно-сосудистыми
cornerstone
заболеваниями.
of
Краеугольный
tackling
камень.
heart
Воздействие на
diseases
популяционном уровне,
because
воздействие на
it
факторы
impacts the
риска,
population level, it
в меньшей
impacts risk
степени
factors,
на
to a lesser degree
воздействие
it
на пациента
influences
высокого риска. И вот,
patients
но
with
надо
high
понимать,
risk.
безусловно, что путь
But we
вложений
need to
в
understand
первичную
that
профилактику до снижения смертности очень велик.
from
Я уже
investments
говорил о нашей
in
особенности,
primary
что у нас
prevention
довольно много
towards
пациентов высокого риска,
reduction
поэтому
of
мы
death rate,
понимаем, что
it's a very
помимо
long way
первичной
to go.
профилактики
We
должна
need to understand that
активно
along with
внедряться
primary
и
prevention, we need to
профилактика, тактический
implement
подход,
very
который
actively
нацелен на
both
борьбу с непосредственными
strategic and
причинами
tactic
смерти,
approaches
подход, который
aimed
нацелен на
at
выявление групп
immediate
высокого
causes of
риска
death,
и
aimed at
коррекцию
identifying
этих факторов
high-risk
риска, в том числе и
patients,
на вторичную
aimed at
профилактику в
correcting
группах высокого риска. И
identified
только
risk factors,
совместный
including in
подход,
high-risk
нацеленный
cohorts.
на
Only this joint
борьбу с неотложными
effort
состояниями у
aimed
пациента
at
высокого риска,
tackling
выявление
urgent conditions
этих
of
пациентов в
patients,
рамках программы
at
диспансеризации,
identifying those
которая
patients through the
реализуется в
global
Российской Федерации
national
последние
screening program,
десятилетия. Вот
which is
именно
underway
два
in
этих
the Russian
направления
Federation
должны
now. So
привести к
those
тому,
two
чтобы уменьшить
areas
смертность от
are
сердечно-сосудистых
meant
заболеваний,
to
уменьшить
reduce the
смертность
general
как за
mortality
счет
from
острых причин,
CCDs,
так и за счет
both
хронических
from acute
заболеваний.
and
Поэтому
from chronic
вот выявление, контроль модифицированных факторов,
identify and control
снижение
modifiable risk
заболеваемости в
factors,
таргетных группах за счет
reduce
активного лечения снижения
morbidity
риска,
in target
это,
groups
безусловно,
owing
крайне
to risk
важное
reduction.
направление.
Those are
Как же можно
two very
продвигать
important
это
areas
направление
to follow.
и
So how can
изменять
we
ситуацию?
promote
Что уже можно сделать
those
сегодня?
changes?
Безусловно, в
What
Российской
can we do
Федерации
today?
активно сегодня
course,
развиваются
Russia is very
направления,
actively
связанные с
developing
телемедициной. Мы
telemedicine.
большая страна, вы знаете.
It's a
У
big
нас
country, it's a
11 часовых
very big
поясов.
country.
И вот мы
11
сегодня,
time
к сожалению, не
zones.
смогли подключить часть наших регионов,
Unfortunately,
которые
today
находятся за
a part of
Уралом.
our
У
region
них уже, наверное, утро
behind
скоро.
the Ural Mountains
Но вот внедрение
were
программы
unable to
телемедицины,
attend for
безусловно,
this
должно
precise
увеличить
region, for
доступность
this precise
медицинской
reason.
помощи,
But
доступность,
this
по крайней
telemedicine
мере,
area
консультативной
is meant
помощи,
to increase the
улучшить
availability of
консультирование пациентов
preventive
высокого
and
риска, и тем самым,
preventive
может быть,
healthcare and
повысить
treatment
их приверженность
to
той
reduce
терапии,
the risk
которую они
factors in patients,
получают.
to
Очень
increase their
важными является
adherence
стратегия
to
борьбы с
prescribed
врачебной
treatment.
инертностью, образовательные
Then
мероприятия.
the
Мы
strategy
рассматриваем,
to
что
tackle
сегодняшний вебинар
physicians'
тоже будет в
inertia is
череде
very
тех
important as well.
мероприятий, которые
And we
будут
think that we do hope
мне
that our today's
действительно
webinar
улучшать понимание врачом важности борьбы с факторами риска, важности использования шкал, о чем сегодня говорилось. Действительно, менять нужно врачебную инертность. Внедрение новых технологий лечения по мере их возникновения. И, безусловно, если говорить о трансляционных исследованиях, то очень много сегодня выполняется в Российской Федерации исследований, которые нацелены на внедрение в практику новейших научных достижений. Таким образом, воздействие абсолютно на все точки, на все барьеры, которые включают и пациента, и отношение пациента к своему заболеванию, отношение пациента к той терапии, которая ему назначается, изменение позиции врача. Отношение врача – это и правильный диагноз, и своевременно начатая терапия, и обозначенные для пациента правильно цели, и это и учет особенностей пациента, безусловно, все это важно. И вопросы организации медицинской помощи, когда мы сегодня все во всем мире потихоньку меняем парадигму оказания помощи, и в фокусе сегодня, вот на верхушке этой пирамиды становится пациент, а организаторы медицинской помощи, провайдеры, страховые компании, госпиталя – это все то, что должно обеспечивать достижение этой цели, связанной со снижением сердечно-сосудистой смертности. Безусловно, вот успех в этом нелегком пути, безусловно, связан с модификацией и воздействием на факторы риска. И я бы хотел задать вам вопрос, все-таки с чем можно, на что можно рассчитывать при борьбе с факторами риска, на какие из перечисленных ответов, это что является главным соблюдение клинических рекомендаций, приверженность пациентов, наличие сопутствующей патологии у пациентов, иначе говоря, коморбидность, или очень важным является учет комбинации всех этих факторов, и только вместе воздействия на эти факторы можно добиться успеха.
The combined tackling of all those factors will allow us to achieve success. Feel free to answer now.
Прекрасно. Можно сказать, что у нас прекрасное будущее и понимание того, что только воздействие на все эти факторы можно добиться положительного эффекта. Должен сказать, что, конечно, очень важным, это подтверждается международными данными о том, что следование рекомендаций не только воздействие на факторы риска, но и исследование приверженность пациента, следование рекомендациям – это залог по меньшей мере 50% успеха. Если говорить о разных группах препаратов, в частности о статинах, о которых мы сегодня говорим много, и о проблеме атеросклероза, то приверженность сегодня в мире варьирует. Это действительно большая проблема от 20 до 70%, при том, что говорим мы очень много о статинах. Если говорить о приверженности у пациентов с артериальной гипертензией, то она тоже, вы видите, колеблется от 60% в течение первого года, а далее уже получается, что менее 50%. Причем факторы, которые влияют на приверженность, являются молодой возраст, уровень образования, употребление алкоголя, все эти факторы, конечно, детерминанты низкой приверженности, низкой компонентности. Но если у человека есть тяжелое поражение сердечно-сосудистой системы, наличие сопутствующей патологии, то это, безусловно, основание для того, чтобы все-таки следовать рекомендациям доктора, бороться с факторами риска и улучшать прогноз. Ну вот в качестве примера, насколько
towards a better adherence of
кропотливая
the
работа
patient.
по борьбе с
Here
факторами
you can
риска
see
может привести к действительно положительному результату. Это наши
an
данные
intensive effort
исследования
could bring
работников
good
банков, когда
results.
через 2 года
This study
наблюдения мы
covered
видим
bank employees
четкий положительный эффект
were followed during 2
адекватной
years.
антигипертензинной
And here we
терапии,
can see a very
значительный
positive
регресс
outcome
гипертрофии
after 2
левого
years of
желудочка.
taking
Безусловно, и это говорит о том, что вот
antihypertensive
если
therapy.
помимо артериальной гипертензии не
It's observed
контролировать
in
у
left
этих
ventricular
пациентов уровень
myocardial
холестерина,
hypertrophy,
и если
but also
не
in
назначать
carotid
своевременно
arteries.
препараты, которые
It means that
снижают уровень холестерина, в
if we
частности
don't
статины, то, к
prescribe at an
сожалению,
early stage
контролировать прогрессивный
such medicines
атеросклероз очень
as statins, for
сложно. Это
example,
тоже, в общем, важный
the more
вывод из
advanced is
этого
the illness,
исследования.
the
Должен
disease,
сказать,
the
что
more
Российское
difficult
кардиологическое общество много
it
занимается профилактическими
becomes
программами.
to
Это
control
и
those
акции,
conditions.
и программа
Russia is
«Здоровое
actively
сердца»,
involved in different
это
international
и
projects
программа
as well as national projects.
«Оденься в
Those
красное»
are projects
для того,
Healthy
чтобы
Hearts.
привлечь внимание к
Then
здоровью
the program
женщин,
Go Red
имеет
for Women,
большой
because
популярность в
awareness
Российской
raising
Федерации.
among women
Ну и буквально
is
несколько
crucial
слов о
for
том,
Russia.
что нас ждет в
Then
будущем.
a couple of words
Безусловно,
about
мы постепенно будем
our way
переходить
forward.
все-таки к
Certainly,
более
we are going
таргетной
to
профилактике,
move on to a
таргетному
more
выявлению
targeted prevention,
лиц высокого
to a
риска
more targeted
и
risk
воздействовать
identification.
не просто
And we are going to
на факторы риска,
tackle not
используя
only risk factors
современную терапию, но
using
будем все-таки
modern
искать генетические,
state-of-the-art therapy. We
эпигенетические
are
механизмы,
also
которые
going to look
ответственны у каждого конкретно
at
больного
genetic mechanisms,
за
epigenetic
развитие
mechanisms that are
сердечно-сосудистых
responsible
заболеваний.
for the development
Будем
of heart diseases in
действительно
different groups of
воздействовать
patients.
комплексно
So we
и
seek
на
to
эпигенетические
provide
такие факторы,
complex
связанные с окружающей средой,
impact on the
компонентами
genetic factors, on
питания.
environmental
Поэтому
factors, on
вклад,
nutritional factors, and so on.
вклад
That's why
изучения
the
молекулярных основ
contribution
здорового образа
of
жизни
molecular science is very important here. We
воздействие
need
на
to study
факторы риска,
molecular
которые
basis of healthy
определяют вот это
lifestyle,
движение
along
длительное
with tackling
от
risk
факторов
factors
риска к развитию заболевания, замедление процесса
allow those
старения,
risk factors to
развитие
transform
профилактической
into a disease.
геномики,
We
ранняя
need
детекция
ensure
молекулярных
slower
основ
aging,
тех или иных
healthy
изменений.
aging.
Безусловно, это то,
We
что
need
будет
to
лежать в
work in the
основе
field of preventive
ценностной медицины,
genomics. So
ценностной
I think
профилактики
that it
и
will be the
определять
basis of the
стратегию на будущее.
value-based
Поэтому,
medicine
но
and
такие
prevention
новые
of the
технологии, как
future.
технологии
That's
редактирования
why new
генома
technologies
у плода
such as
детей и взрослых, коррекции
genome editing,
эпигенетических нарушений.
correction of
Ну, это,
epigenetic
безусловно, все подходы,
and
которые
every
будут
other
основываться на
approach
модификации
based
образа
on the
жизни,
modification
изменении
of
окружающей
lifestyle,
среды с учетом и генетики, с учетом
taking into
метагеномных и
account
геномных
genetics,
взаимоотношений.
environmental
Это поиск
factors,
индивидуальных
genome
маркеров
and
риска
genomic
и
and
индивидуальная
metagenomic
профилактика у
relationships
каждого человека
will
на
be
молекулярном
key
уровне.
efforts.
Поэтому, безусловно, мы
Looking forward,
сегодня движемся в
allowing
сторону
to
смены
determine
парадигмы,
the patient's
которая
profile on the molecular
будет
level.
учитывать
So we are
и
moving
контроль
towards
факторов риска
a
и поведенческими
paradigm
факторами
shift,
риска и не только,
which will also
но
include
и
behavioral
нам предстоит
factors,
действительно определить,
behavioral
найти
risk factors,
истинные причины и
and
научиться
based on all those
воздействовать
criteria,
на
we'll
геномном
need to
и
find real
постгеномном
causes
уровне.
of
Ну и последнее, я бы хотел поделиться с
CCDs
вами
and to
нашим
influence on
проектом,
them
который
on genomic and
нацелен на
metagenomic level.
изменение
And the last
ситуации в
project I'd
Петербурге.
like to share with you
Есть
is the
успешный
project
опыт у
aimed
наших
at
соседей в Финляндии, проект
changing
Северная
the situation
Карелия.
positively in
Есть
St.
успешный
Petersburg.
опыт изменения
We rely on the very positive
эпидемиологической
experience
ситуации и
of North
ситуации
Korea,
заболеваемости и смертности
which is
в
very
других
close to
городах,
us.
так в Шанхае.
We also rely on the experience of other
В этом году
cities.
доложено
For example,
в
Shanghai.
Китае и принята соответствующая шанхайская
The
декларация, которая
successes of
говорит о том,
Shanghai
что
program
ситуацию
were
можно
related
изменить,
in China
и
this year
необходимо
and
тесное взаимодействие
led
всех
to the adoption of the
структур, которые
so-called
заинтересованы в охране
Shanghai
здоровья, не только медиков,
aimed at
и,
transforming
безусловно,
regional, local, global
перечень мероприятий,
healthcare.
которые сегодня
So here you
будут
can see the
реализованы
list
в рамках
of
пилотного
measures
проекта,
and events
которые будут связаны с
that are
оценкой
planified
эффективности
within a
медицинской
pilot
помощи,
project
с
aimed at the
изменением образа
assessment
жизни,
of the
питания,
efficiency of
с
healthcare,
более эффективной
aimed
помощью
at
при неотложных состояниях.
nutritional and
Вот все
dietary
эти блоки
changes changes of approaches to urgent conditions and so on. So all those new approaches, all those new projects are going to be implemented next year, and it will hopefully show that even in a large city, it is possible to change the situation in a positive way. Thanks again for the organizers, for the co-organizers, from the American College of Cardiology, for this opportunity to present all those data to you today. Thanks a lot.
Well, thank you so much, Professor Shlakto, for that excellent discussion.
Огромное спасибо, профессор Шляхта, за прекрасную презентацию, которая позволила нам понять не только историю сердечно-сосудистой
in Russia, but also the exciting new strategies for reducing cardiovascular morbidity and mortality in the coming decade. I'd like to now turn to introduce our final speaker of the evening, Dr. Seth Martin.
While we're loading the slides, let me just say thank you to Dr. Morris. Thank you, Dr. Shlakto. Thank you, everyone in the audience and online. It's truly an honor to be here in Russia and to collaborate with the Russian Society of Cardiology. Spasiba. Okay. So once again, it's a true honor. I'm just going to see if my pointer works here. Okay, so if you want to follow me, at least you'll be able to see my pointer on this one version. So this final talk is really about the treatment, the implementation. So these are guidelines for the treatment of blood cholesterol to reduce atherosclerotic cardiovascular risk in adults. So we're going to focus in on cholesterol for this presentation, but place it in the context of multiple risk factor modification. My disclosures. So we have two key objectives, and these were informed by the needs assessment prior to this conference. The first objective, to adopt guidelines to create evidence-based management strategies for patients. And secondly, to comprehensively address multiple risk factors, and as I mentioned, really going to hone in on cholesterol management in primary prevention practice. So starting first with the rationale for guidelines, and we're going to use this term ASCVD, atherosclerotic cardiovascular disease. But first I want to start with an interactive question, and I believe you can register your responses as I read this off, so as soon as you feel comfortable, go ahead and do so. Which of the following statements reflects your use of ASCVD guideline recommendations? First, I am not familiar with the data supporting either ESSE, EAS, or ACCHA guidelines. Secondly, I do not have time to follow the guidelines in my practice. Thirdly, I do not agree with all of the guideline recommendations for ASCVD prevention. Fourth, I try to follow ESSE-EAS guideline recommendations. And fifth, I try to follow ACC-HA guideline recommendations. So I have my guess of what this is going to look like. What's that? Oh, closer. Okay. So here we have the answer, and the one that we see most common at 2/3 of the audience, or 64%, is what I had expected following the ESSE-EAS guidelines. And our online audience is even higher at close to 80%, but there are some, about 20%, trying to follow the ACC-HA guidelines, so very interesting. So why do we have guidelines in the first place? And the foundational recommendations, they really serve as this foundational recommendations for clinical practice, and so that we can base our decisions in clinical evidence, particularly randomized controlled trial evidence. And these guidelines serve as a way to distribute the contemporary evidence to those out in the front lines of care. Yet we all, in many different countries, including the US and around the world, struggle with implementation of guidelines, especially keeping up with the latest evidence. So in terms of suboptimal implementation, this may be due to low awareness of guideline recommendations, although I've been very impressed by the audience's awareness during these presentations. Number two, the lack of agreement. You may be aware, but you don't agree that that's what the evidence shows and it's best for your patient. This concept that was already brought up of clinical inertia, this desire to sit tight rather than to intervene and manage risk. And then cognitive overload, just having too much to do. Can we address all these different risk factors in one visit? So when we think about modifiable targets in primary prevention, as shown by the InterHeart data earlier, there's several that we can target. Honing in on LDL, which has been, and this came up in the pre-test, this has been recognized by guidelines around the world as having a central causal etiologic role in the pathogenesis of ASCVD. Landmark statin trials show that LDL is strongly associated with increased cardiovascular risk, and there's this log linear relationship of LDL levels and the relative risk of coronary heart disease, with studies as early as WASCOPS on the steeper part of the slope here, where patients were started at much higher LDL levels, many with FH, familial hypercholesterolemia, and then down to more recent studies like PROVE-IT-TIMI-22 in the post-ACS setting, where patients after that acute coronary event, starting even at much lower LDL levels, benefiting in terms of their risk reduction. And there is going to be some redundancy in this presentation, and the purpose of that to highlight some of these very critical points. So here we show some of the key trials, the landmark statin trials that have shown that lowering LDL cholesterol reduces atherosclerotic cardiovascular disease risk. So as I had mentioned, WASCOPS, there's AFCAPS, TEFCAPS, and ASCOT. These are primary prevention trials. And then in secondary prevention, 4S, CARE, and lipid. And we see in these trials various doses, regimens of statins that have been used, and we'll get into later in the presentation what is moderate versus high intensity statin therapy. But using these various regimens, there we go, starting at higher LDLs or even starting as in ASCVD at an LDL cholesterol of 133, when we get that percent reduction in LDL in the moderate range here, we're seeing marked relative reductions in coronary events in the 30% range. Same in secondary prevention, where we're getting those relative reductions of 20 to 30% with similar LDL reductions. And these days, we can get much more robust LDL reductions, as we'll get into. So when you take all the statin trials combined in a meta-analysis by the cholesterol treatment trialists, that shows that there's a 20 to 25% relative reduction in major cardiovascular events for every 1 millimole per liter reduction in LDL cholesterol. So moving into the guidelines, taking a deeper dive into the guidelines for managing ASCVD risk, we have first another interactive question, and this is with respect to the ACC guidelines. And as many people are following ESC, this may not look so familiar, but again, feel free to register in as I read off the question. So the ACC cholesterol management guidelines recommend discussing statin therapy with which of the following patients? Those without CVD or diabetes, aged 40 to 75 years, with advanced heart failure. Those without CVD or diabetes, age 40 to 75 years, with a lifetime ASCVD risk less than 5%. Those without CVD or diabetes, age 40 to 75, with a 10-year risk of 7.5% or more. And then finally, those without CVD or diabetes, age 40 to 75, with end-stage kidney disease on dialysis. So we'll take a moment to let the answers register. Okay, so 80% got answer 3, and I'm very impressed, actually. This was a bit of a tricky question, and I'm very impressed. And same with the live audience, we have the majority of folks answering number 3, which is correct. This was one of the statin benefit groups in the ACC guidelines, this 7.5% or above risk group. I will make one brief comment on answer 2. The lifetime risk in those guidelines is the ACC guidelines is largely directed at encouraging changes in behavior, diet, exercise, not so much in terms of decisions regarding statin therapy. And a lifetime risk of 5% or less is very, very low, as has been shown in slides earlier. When we get one risk factor, we're often talking about lifetime risks of 36% or above. Okay, wonderful. You guys did really, really well. So in terms of ASCVD prevention guidelines, we have many different guidelines around the world. And some of the most notable are the ACC guidelines. And there's also the ESC guidelines, which you all then work to translate into your own local practices. And one of the advantages of these ESC, EAS guidelines is they're kept very up to date, the latest version being released just this past summer in Rome. So when we look at the various guidelines around the world, we want to emphasize the areas of concordance, and this gets into another question that was on our pre-test prior to this conference, And the guidelines are very much in agreement that a healthy lifestyle is a foundation of prevention. This second point is particularly important for your pretest, that guidelines agree on this etiologic, on this causal importance of LDL in ASCVD risk, that this has been shown genetically in randomized trials in many different types of studies that LDL is clearly a causal factor, and we probably have as good of evidence for that as we have for just about anything else in medicine. The intensity of therapy should be matched to the risk of ASCVD, and this risk may come from SCORE, it might come from ACC-HA, it depends on your local setting where that risk will come from, but the guidelines do agree on matching to that absolute risk. And then finally, statin therapy is the mainstay for reduction of LDL-related ASCVD risk. The guidelines are in agreement on this. But guidelines are not rules. The clinical judgment still remains important. We must practice the art of medicine. And this starts to get into some of the comments that I'll make later in terms of the importance of shared decision-making. So continuing on with guideline recommendations for primary prevention, this is a slide to emphasize the healthy lifestyle agreed to by all the guidelines around the world as a foundation in prevention. And when we talk about the type of diet, of course, this is going to vary based on your local culture. But in general, what is recommended by the AHA are diets rich in whole grains and fiber, vegetables and fruits, fish and legumes. These are the types of major food items that can be viewed as heart healthy. And one of the types of diets that's been actually studied in randomized trials is the DASH diet as well as the Mediterranean style diet. Dr. Schlachto made comments earlier, showed data on alcohol consumption. And in terms of alcohol, moderation is advised, basically 20 grams per day or 2 drinks per day for men and 1 drink or 10 grams per day for women. And in terms of physical activity, the recommendation from our guidelines is about 30 to 40 minutes of exercise daily, and this is moderate to vigorous activity. It may be something as simple as taking a brisk walk during your lunch break at work, but this is something that is recommended to be done at least 5 times a week, if not daily. Weight reduction is critical, as is smoking cessation counseling. So what are the tenets of lipid-lowering therapy? So the tenets start once again, and this is intentional repetition for the key points. Statins as the cornerstone of pharmacologic therapy. Absolute risk is key criterion for therapy intensity and allocation based on many different guidelines. There are 4 statin benefit groups in the ACC-HA guidelines, and these were identified based on where the randomized controlled trials showed evidence of benefit, of net benefit, where the benefits outweigh risks. Next is initiating a statin, and if you're following the ESC guidelines, using the SCORE, as Dr. Virani showed very eloquently earlier. And lipid-lowering therapy should be individualized, and I'll make further comments on this later. So this gets to another interactive question, and again, feel free to enter your response as soon as you're ready. And this is a bit of a subtle question here with the answer choices, but what percentage of LDL reduction would you expect from low, moderate, or high-intensity statin therapy according to the 2013 ACC-HA cholesterol management guideline? And so here we have the choices of low, moderate, and high, and you see these percentage choices varying for the different answer choices. I'm going to spare going through all the percentages, but please register your response and we'll see how people do. This does come from the ACC-HA guidelines. This chart, however, really is relevant to practitioners throughout the world. Okay, so here we have a distribution of responses, and this is what we have from our audience here, where most did say 31%, which is the correct answer. A lot of other choices as well, and we're going to have our live audience results come in here, where we have close to 60% choosing the last answer, which the high-intensity statin therapy is classified as giving a 50% or more reduction in LDL cholesterol, and moderate being that 30 to 49% reduction. These are based on averages, average responses in clinical trials, where the randomized group that gets intervention has 50% or more response, such as in the TIMI 22 study, as compared to the placebo group. Not every patient's going to have that same response, but this is what to expect based on the average. So when we look at those statin benefit groups from the ACC/HA guidelines, we have those who are secondary prevention with clinical ASCVD, those with primary elevations in LDL cholesterol of 190 or more milligrams per deciliter, 5 millimoles per liter. Many of these patients may have familial hypercholesterolemia and had this elevation since birth. Those who are 40 to 75 years of age with diabetes, and those without clinical ASCVD or diabetes who are 40 to 75 with a 10-year risk of 7.5% or more. So this is the threshold to consider a statin in that last group. For drug therapy in primary prevention, the ACC/HA recommend moderate to high-intensity statins that will, on average, reduce LDL 30 to greater than 50%, so that moderate to high-intensity statin therapy, unless there's a good reason not to. So again, some purposeful redundancy in the slides, and we see those 4 statin benefit groups once more. And then we see matching to the intensity of statin therapy. So in the clinical ASCVD risk group, using high-intensity statin therapy, unless someone has a reason not to, because they're older, you may go down to a lower intensity. Those in that LDL, very high LDL group, using high-intensity statin therapy. In the diabetes group, one interesting approach that was taken here was to then use the risk score, and if it's 7.5% or more, then to recommend high-intensity statin therapy, whereas the overall risk is lower to use moderate intensity. And then outside of that setting of diabetes, if someone is being triggered for a consideration of statin based on the pooled cohort equations, which give that risk score, then it would be moderate to high-intensity statin therapy. But let us not forget that heart-healthy lifestyle is the foundation of therapy. So this concept that comes up throughout guidelines around the world, that matching intensity of risk-reducing therapy to CVD risk, and that has to do with how high risk someone is. Do they already have ASCVD? Do they already have very high LDL? And that absolute risk is guiding us based on that moderate or high-intensity statin therapy. But this is a very nice chart from the ESC guidelines, where we also think about how, if you're going for a certain LDL reduction, how far do you have to go? And so if you're starting very high at more than 6.2 millimoles per liter, you have a ways to go, and if you want to get down to less than 1.8 millimoles per liter in a very high-risk patient, and that's going to take more than a 70% reduction. We're talking about combination therapy to get down there, and we'll get into non-statins that you may use on top of statin therapy, as compared with someone who's starting at the lower range of LDL cholesterol levels, who has LDL cholesterol maybe of about 3 millimoles per liter. With moderate intensity statin therapy, you may be able to get them down to a very low LDL cholesterol. So I said I'd come back to this, matching intensity to risk-reducing therapy. And here, in terms of how intense these statin regimens are, this is the chart that goes into more detail. So in terms of the daily dose lowering by 50% or more, you see in this most left-hand column, the regimens there, it's quite simple actually. It's either a atorvastatin 40 or 80 milligrams per day, or rosuvastatin 20 or 40 milligrams per day. Then when we get into the moderate intensity category, we have a lot of options, and it might be lower doses of the atorvastatin or the rosuvastatin, or it may be one of these other statin medications that you see, simvastatin, pravastatin, et cetera. And then low-intensity statins would only really be used if you can't get the patient to tolerate one of these other regimens. So this is a really nice summary slide of all of the different statin trials. And what's been shown is that large randomized trials reduce LDL, but yet there's still residual risk. The risk, this is the event rate. And we see that throughout these trials, even when getting to very low LDLs, there's residual risk. Part of that might be the fact that someone already has advanced plaque that starting therapy late in life is not going to cure, but part of it is controlling those other risk factors. And so we'll talk more about that. The cholesterol treatment trialists have provided us with tremendous data for statins in both the efficacy as well as safety. And so as shown in this forest plot, we see that basically, as mentioned earlier, for every 1 millimole per liter lowering of LDL cholesterol, we're basically reducing the relative risk of disease by 20%. And so more intensive statin regimens will further reduce coronary events. When someone starts at a higher LDL, they're going to get even more benefit from that absolute lowering of LDL. So we're going to make a transition now from statins to non-statins. But first to say that statins are typically safe for long-term use. They've really been well tolerated by the majority of patients. And even when patients struggle with a statin at first, often when they're re-challenged, it then goes well. Muscle-related symptoms and diabetes are known but uncommon. Diabetes often occurring in a statin-treated patient, not out of the blue, but in someone who was predisposed to developing diabetes because of prediabetes, metabolic syndrome. Non-statin agents can be considered in statin-intolerant patients, and also those who have an insufficient response to the statin or simply have such a high LDL at baseline that they need combination therapy. So the Improve It trial, a 18,000 patient trial, was very exciting in that it was the first trial to show us benefit in terms of cardiovascular events on top of statin therapy. And this trial met its primary endpoint. Now, Zetia has, or ezetimibe has a modest lowering of LDL cholesterol, about 20%. So in line with that, the actual reduction in cardiovascular events is fairly modest. But over the course of 6 to 7 year follow-up, we see, and it is shown in this blue curve, those who are treated with simvastatin monotherapy as compared with, in the red curve, simvastatin ezetimibe combination therapy. And that group with combination therapy got down to an LDL level of about 50 as compared with 70 in the simvastatin monotherapy group. And as I mentioned, when that was done, this resulted in improved cardiovascular outcomes and supports the consideration of non-statin therapy with ezetimibe in high-risk ACS patients or acute coronary syndrome patients. What about the new kids on the block, PCSK9 inhibitors or pro-protein convertase subtilisin Kexin type 9? I wonder how the translation goes for that one. So this is a meta-analysis of 24 trials with 10,000 participants in those trials. And what we see in the fixed effect model, and I'm going to blow this up so that it's easier to see the results, is a statistically significant reduction in mortality, in death, when someone is treated with a human monoclonal antibody to PCSK9. The odds ratio was 0.45, and that was statistically significant. And there were similar reductions in cardiovascular mortality and MI. And this, I wanted to also mention, this came out back at the end of 2015, and coming up at our ACC meeting in Washington, D.C., just very soon in March, in about a month, the results of the Fourier trial of one of these monoclonal antibodies, evolocumab, will be presented. But it's already been reported, the top-line results, that that trial has met its endpoint for cardiovascular event reduction. So this is a very exciting time in preventive therapy. The other key point about PCSK9 inhibitors is that they lower LDL a lot, 60% on average with the current clinical treatments. So as much, if not more, than the high-intensity statin therapy. So the two of those combined, or in 3 with Zetia, can permit the vast majority of people to get to very well-controlled LDL levels. So coming towards the final part that I'd like to share with you is putting this risk management into practice. And this comes back to the comment, as Dr. Schelotto had mentioned, there's this paradigm shift where things are becoming more centered on the patient. And this is implemented in practice by shared decision-making. And what we are seeing is this may improve adherence to therapies and yield better health outcomes. Patients may want to take an active role in their treatment decisions with their physicians by talking to them about the treatment, not just giving the prescription, but why, and getting that buy-in from the patient, we think could lead to better healthcare engagement and better adherence and better outcomes. So this hinges really on two-way back and forth conversation, and as Dr. Virani mentioned, may occur over several visits. It might not be all accomplished in the context of one clinical visit. This is something that was felt to be very important by Dr. Stone, the leader of the last ACCHA guidelines, and for that reason we highlighted in a paper in the leading cardiovascular journal in the US, JACC, and this was the table that had been shown earlier. But what this is about is discussing the options to reduce ASCVD risk. That if someone is in those statin benefit groups, for example, that fourth group, 7.5% or more, it's not that that person must take the statin. Although there is evidence that there's benefit, it's going to require a conversation with the person to understand their goals and their therapy. And it might be that they choose that they want to only focus on the smoking cessation first, which might be perfectly reasonable, and you'll come back to this later. So that it's not that they must take it, but if they are ready and you have that buy-in, it would make sense to then go ahead and treat. But it requires first that conversation. During that conversation, we're talking about taking a comprehensive approach. And so you're not, even though we have great evidence for the cholesterol therapies, we're not forgetting the rest of things. Prevention is about a comprehensive approach, and that's what this discussion acknowledges as well. So reviewing the diet and physical activity habits and endorsing the importance of that healthy lifestyle as a foundation of therapy. if they are interested in discussing the statin, explaining the benefits, sharing with them the evidence, what their risk is, and the benefit of statins and the safety data for statins. When talking about safety, Dr. Stone came up with this 5 M's, and this was something that had come up with the needs assessment as a key area in terms of discussing statin safety. So the first M is for metabolism, that small risk of new onset diabetes, which a key point being that it's in folks who are predisposed who are on track, and I'm going to try to point here. It's kind of small. I'm referring to this section here, initiation of the statin, and then the 5 M's here. So metabolism, that small risk of new onset diabetes, and folks who are predisposed. And this is something that comes up a lot in clinic, and it's been a lot of attention in the literature to this issue. But it really is a small risk, and this is an opportunity to talk to the patient that one of the best things that they can do to prevent diabetes is to avoid sugary drinks, to eat healthier, and to get physical activity. Muscle, so is the second M. Muscle symptoms can occur quite frequently, although in randomized trials, this has not been nearly as much of an issue as it's been out in clinical practice. And it's worth, if someone has these muscle symptoms, evaluating for other potential causes as well. Medication interactions, so there are possible drug-drug interactions, particularly in elderly patients, and that's one thing to take note as you have this discussion and review the medications. In terms of major organ effects, it was once thought that there were major risk of toxicity to the liver, and liver tests were routinely checked. These days, we don't routinely check liver tests in clinic, and it's really quite a rare possibility that that would be an issue. And then finally, there's been a lot about the last M, memory, the idea that statins might reduce memory, and it's even been in newspapers that statins cause people to be, quote unquote, dumb. This has not been something that's borne out in high quality studies, in both prospective observational studies as well as in clinical trials. There has not been shown to be a negative effect of statins on memory. So this is the, moving on to the right side of this slide, the 5 Ps. This is another potential way to remember some of what you want to go over with the patient. First, what is their preference? What is their priority? Do they have a family history, as Dr. Varani had mentioned earlier, and they're highly motivated? They want to do everything possible to prevent cardiovascular disease. Or are they someone who wants to focus on something else at the moment? What is their preference? How precise is that risk estimate that you have? Or should you think about some other test, like atherosclerosis imaging, to help you understand the risk better to make a decision? Third, how motivated participation is the patient to engage in these lifestyle changes and buying into the medication? And fourth, the potency. What treatment and dose are you looking at going with? And then fifth, this has been a big issue in terms of statin adherence, is the price. Oftentimes patients have been prescribed medications that they then can't afford, so making sure that those fundamental issues are addressed. So in summary, and thank you very much for your attention throughout, global guidelines recommend statins as first-line therapy to reduce ASCVD risk. Secondly, non-statin therapies may play a role in select high-risk patients when response to max-tolerated statin is less than anticipated. And some of the key therapies we consider are ezetimibe and PCSK9 inhibitors. Thirdly, and this is very important for that test assessment, is the LDL is considered etiologic by all guidelines around the world, as compared with HDL, which we don't believe is causal these days in atherosclerosis. So that LDL is etiologic, and it remains important to monitor that on therapy for adherence, as well as to decide about additional therapy. And then finally, bringing the patient to the center of the care and decision-making, and shared decision-making and the clinician-patient risk discussion being key, absolutely key to successful guideline implementation. Thank you very much. Spasibo.
Well, thank you so much, Dr. Martin. And I'd like to take this opportunity to give a nice round of applause to all three of our magnificent speakers this evening. So thank you so much. As we're getting ready, we're going to now be having our question and answer session. I just wanted to give a few sort of takeaways from the three discussions that we've had today. I think one of the things that was most exciting to me was that the majority of our both in-person audience and our live stream audience are using a risk calculator. So there were very few that answered that they were not using a risk calculator, and the majority were using the score calculator. So I thought that was very encouraging today. I was very excited to hear about the statistics here in Russia, the declining prevalence of disease, the reduction in morbidity and mortality that has been achieved in recent years. One of the things I found very interesting was the changing definition of obesity from the BMI to the waist circumference, which I think is extremely relevant now with this epidemic of obesity, which is global, and the coexisting epidemic of diabetes. I was also very impressed by the importance of strict tobacco regulation. We may somewhat be lagging behind you in this respect, as we are still working very hard to implement nationwide smoke
по внедрению неких сред, неких областей без курения по всей стране, во всем США, поэтому нам очень важен ваш опыт. Кроме того, программа «Здоровые города», которую вы сейчас начинаете, мне очень понравилась. И, наконец, интересно то, что и господин Шлихто, и доктор Мартин говорили о важности клинической инерции. Это огромная проблема, с которой сталкиваются и Соединенные Штаты в Америке. Как я вижу, здесь проблема та же самая. Здесь у нас есть некие рекомендации, они основаны на фактических данных, однако клиницисты иногда не особо-то стремятся их выполнять, эти рекомендации. Поэтому крайне важно, чтобы пациенты тоже знали о фактических данных в основе назначенной терапии. Также очень много было разговоров о том, насколько разнятся рекомендации, и тут я даже не совсем согласна с докладчиками. Мне кажется, что надо концентрироваться на том, что объединяет эти рекомендации, а не то, что делает их разными. Особенно у пациентов высокого риска, как сказал последний докладчик, очень важна терапия статинами, высокоинтенсивная, среднеинтенсивная. И, наконец, спасибо за прекрасные новости о том, что появляются результаты новых исследований с ССЗ. Надеемся, что в дальнейшем эти исследования можно будет вести вместе. В марте будут представлены новые результаты. Ну что ж, я хотела бы передать слово нашим уважаемым коллегам, которые сейчас занимаются очень важным вопросом. Они сейчас будут передавать нам вопросы, которые были заданы в сети интернет. И вот доктор Александр будет модератором этой сессии вопросов и ответов.
Глубоко уважаемые коллеги, у нас есть 15-20 минут для ответов на вопросы, которые я предложил бы чередовать. Вопросы из зала, вопрос из сети, которых набралось достаточно много. Я обращаюсь к тем, кто сейчас находится в сети. Мы ответим обязательно на все вопросы, которые были сформулированы. Они все записаны, и вы все получите вопросы, если мы сегодня не успеем. Итак, коллеги, вопросы из зала. Ко всем трем докладчикам.
Welcome the questions from the floor to three speakers. to the three speakers,
Ну, тогда, пока вы
please.
думаете, я
Okay,
начну
while you are
с
thinking over
максимально
those questions,
провокативных вопросов
I
из
will
сети.
start with the most provocative
Было
questions
несколько
from the web.
однотипных
There were
вопросов,
some
в
questions
частности,
of one only
и ответ на этот вопрос меня,
belonging to
например,
one
очень
type,
интересует
and I'm
лично.
very interested
Итак,
in the
у
answer
нас
to this
есть
question
человек,
personally.
я
For example, we
подчеркиваю,
have
не
an
пациент,
individual, not
а
patient,
человек,
but an
без
individual
сердечно-сосудистых
with
заболеваний,
no
без артериальной
cardiovascular
гипертензии,
diseases, with
без
no
факторов
AH, with
риска,
no
без
risk factors,
ожирения,
with no obesity,
в возрасте от 30 до 40 лет,
aged between 30 and
с уровнем
45,
холестерина
and cholesterol
8 миллимоль
level
на литр.
8 millimole
Надо ему
per
назначать
liter.
статины или нет?
Do
Таких
we need
вопросов было
to
несколько,
prescribe
по-разному
statins to him or not? There were several questions of this kind, formulated differently, but the meaning is the same.
Hello? Yeah.
Да. Насколько я понял вопрос, у нас человек возраста 40-45 лет с очень высоким холестерином и с отсутствием других рисков, факторов риска ССЗ. Даже без семейного анамнеза. Скорее всего, это как раз человек, который относится к группе, которая получит максимальную пользу из терапии статинами.
Before 40-45, you likely would want to know, because it's possible this could be someone who inherited a mutation, for example, in the LDL receptor, and they have familial hypercholesterolemia, and that is the reason that it's so high. There are other secondary causes, but that would be at the front of my mind is this FH, familial hypercholesterolemia. In that setting, it would be strongly recommended to talk to that patient about statin therapy. And in fact, given the LDL is so high to begin with, very likely I'm going to be thinking about combination therapy in such a patient.
So I would agree with what Dr. Martin said. If we assume that these are total cholesterol or LDL cholesterol levels of 8 millimole, is it total or LDL?
There were no data in the question.
Okay. So if it's total cholesterol of 8 millimoles, we're looking at about 320 milligrams per deciliter roughly. So in all likelihood, unless this patient has triglycerides, of 1,000 or HDL cholesterol of 100, most likely this patient has LDL cholesterol that's above that 190 milligram per deciliter, or about 5 millimoles per liter that Dr. Martin talked about. So in all likelihood, this patient actually has familial hypercholesterolemia. So in these cases, the recommendation is to actually not even perform a risk assessment, because these patients already have very high both short-term as well as long-term risk of cardiovascular disease. So this patient will most likely need a statin therapy discussion, and in all likelihood may even need something more than statin, as Dr. Martin said.
Я думаю, что прежде всего я должен согласиться с доктором Мартин, что этот пациент требует углубленного исследования и поиска, возможно, каких-то генетических нарушений, которые лежат в основе этих серьезных нарушений липидного обмена. Просто так ничего не бывает. И если это подтвердится, то это будет основание, безусловно, для терапии статинами, может даже комбинированной терапии.
Professor Schlachto, I'm interested to know how readily available is genetic testing for familial hypercholesterolemia in Russia?
Это совершенно доступно для практически в любом городе. И если, я думаю, что даже очень много сегодня групп, центров, которые интересуются такими пациентами, которые формируют регистры таких пациентов. Такая обычная практика.
So one point I would like to make here for both our live meeting attendees as well as those who are listening to us online, that in this case it's extremely important not to forget about patient's family. So if this patient has any siblings, they all need to have their cholesterol tested. If this patient has kids, they all need to be tested, because we all need to remember that FH is autosomal dominant. So 50% of this patient's kids, or if this patient has siblings, there's a 50% chance that someone has actually very high cholesterol. So in these cases, it's extremely important not to keep that discussion just to that particular patient, but then to expand it for the patient's entire family.
Thank you very much. И, коллеги, кто-нибудь, пожалуйста, пожалуйста. Пожалуйста, микрофон возьмите.
Маша.
Речь идет о беременных женщинах, у которых с точки зрения физиологии...
Вас переводчик не слышит, поэтому мы не можем перевести. Говорите, я буду переводить тогда. Давайте так.
Речь идет о категории беременных женщин, которые имеют позднюю беременность. В этой ситуации каким образом коррегируется прогноз и схема терапии статинами?
If we are talking about pregnant females who are, well, at a certain level of age, what could you, well, tell us about the statin therapy in this particular group of patients?
I can start. So the question relates to pregnant females and treatment and safety of statin therapy in that population. This is a challenging situation because cholesterol therapies are largely contraindicated in the setting of pregnancy, including statins, but also others such as Zetia. This is a situation where we may hold the statin therapy during that time and resume it afterwards. If someone has an LDL problem, one thing to consider is that the risk is cumulative risk of being exposed to those very high levels over many, many years. So holding it during 9 months may not be the biggest issue in the world. Things can become trickier when you have a triglyceride problem, in which case many do view it reasonable to use omega-3 fatty acids, such as, I'm not sure if the Lavazza is the same brand that's here, or Vasepa, fish oils. In terms of LDL control, it is considered reasonable to continue a bile acid sequestrant during pregnancy. If someone's in very serious situation, apheresis, LDL apheresis could be considered during pregnancy.
Well,
I would agree. The one comment I would make, since I direct the Women's Heart Program, I follow a lot of these women. I generally have my female patients let me know about at least, preferably 2 months to 1 month, 1 month prior to discontinuing any form of contraception. Will then discontinue the statin therapy throughout pregnancy, and then we will not restart the therapy until they have finished with breastfeeding. The only exception to that would be, again, for a bile acid sequestrant, or for a patient with very severe familial hypercholesterolemia and established cardiovascular disease, then I may consider LDL apheresis. Anyone else? Okay.
Оксана Петровна, у вас был вопрос? Нет. Микрофон все равно нужен, потому что и вас не слышат в сети вас видят и слышат.
According to the last European guideline on cardiovascular operation, we shouldn't use aspirin in primary
Sure, I can take that question. That's actually a very provocative question, not just for Russian audience, but even for American audience. So if you look at what we use is the U.S. Preventive Task Force recommendations in U.S., and if you look at the most recent recommendations that were made last year, was to perform 10-year risk calculation, and if the 10-year risk is more than 10%, then consider aspirin therapy if the patient is between the age of 50 to 60 and can take aspirin therapy for at least 10 years, and they are not at high risk of bleeding. So all those conditions have to be met. And even then, the recommendation was brought down from a recommendation level A to a recommendation level B. So, just to summarize all the aspirin data, if you look at the first 7 trials we had for aspirin therapy, most of them were positive. If you look at the last 4 trials that have happened, randomized control trials, all 4 actually have not shown benefit of aspirin therapy in primary prevention. We're not talking about secondary prevention here, let's make that clear. We're talking about those who do not have any heart attack or stroke history. So I think most of us in the prevention world believe that this day and age, when you have statins on board, good control of blood pressure, the incremental benefit of aspirin therapy is minimal. On the other hand, the risk associated with aspirin therapy, a major GI bleed or intracranial bleed, actually those are much more significant side effects compared to somebody having muscle aches or pains while on a statin. So most of us in those cases would prefer to use a statin, and then if we have further risk, then go towards aspirin. The other thing with aspirin is that there's good data that it decreases the incidence of colorectal cancer. So generally the way I look at it is if I have a patient who's in that age range, and that's why the recommendation is that they can take it for at least 10 years, because for cancer prevention, you have to take it at least for 5 years, preferably 10 years or more. So if you have a history of cardiovascular disease and cancer in the family, once I have started the patient on statin after having discussion with them, if they are interested and they do not have high risk of bleeding, then I usually start a discussion about aspirin therapy, which has definitely changed compared to what it was 10, 15 years ago. So that's where the recommendations are, and remember, these are recommendations, these are actually not guidelines. The aspirin guidelines for American Heart Association, American College of Cardiology have not been updated since all these new data came out.
Окей. Есть еще группа вопросов, которые я бы обобщил следующим образом. Каковы риски у больных с очень низким уровнем холестерина и липопротеидов низкой плотности, как первичным, так и достигнутым в результате терапии? Таких вопросов несколько, они отражают общую обеспокоенность, которую надо снимать.
Yeah, I'm happy to take this one. This is a very interesting issue of the safety of very low LDL, and we're learning a lot more about it because of the new therapies that I mentioned in the presentation. The short answer is that it's very safe when patients are treated with combination therapy, someone who's on statin plus ezetimibe plus a PCSK9 monoclonal antibody. Patients in the trials are getting down on average to LDL cholesterol levels in the 30s, and many of the patients in the trials are getting down to levels less than 25, less than 15, practically getting LDL cholesterol levels of 0 and doing just fine without any safety issues. And this is compatible with the genetic evidence, where people are born with genetic mutations so that they have very low LDL levels throughout life, and they do just fine with that. So we're learning more about the safety of very low LDL, and it's been very reassuring to date. We still need to continue to study it over the long term, these very low levels over 5, 10, 20 years, and certainly that'll be continued practice in the research community to follow these patients. But so far, the evidence has been very reassuring. My one final comment that I'll make is outside of the treatment setting. If you have an untreated patient with very low levels, then they were born with a genetic mutation that gave them that, and it's probably a very good thing. Or you have to think about other reasons. If they're malnourished, sometimes it can be in the setting of comorbidities like cancer. So your radar should go up about those types of conditions if it's outside of the treatment setting.
And just to add to what Dr. Martin said, all of those things we usually think of exactly as he said. The other thing is that the PCSK9 trials, when they started the outcomes trial, 4A trial, which is going to be presented in March, FDA had mandated a safety trial as well, because in some of the earlier trials, there was a signal that with very low LDL cholesterol levels, there could be some cognitive impairment. So there was a trial performed related to that called Ebbinghaus, which again is going to be presented next month, but as per the media release, what we've heard is that actually that safety signal, even in terms of cognitive impairment, was not seen. So overall, lower levels of LDL cholesterol, at least up to 2 to 3 years of follow-up that was shown in those trials, does not seem to be associated with any severe side effects or any problems that we can find out as of now, except in one meta-analysis, and Dr. Morris can correct me, seems like there is some increase in the risk of cataract, but I would rather take cataract than have a heart attack or a stroke.
I would just like to ask a question of Professor Schlachto. I was wondering, what is your approach to the use of the non-statin therapies, both ezetimibe, the bile acid sequestrants, as well as the PCSK9 inhibitors?
Спасибо большое за этот вопрос. Я должен сказать, применительно к нашей дискуссии, что появление новых групп препаратов, в частности PCSK9-9, PCSK9 препаратов, оно, безусловно, сыграло свое очень позитивное влияние на нашу оценку эффективности и безопасности проводимой терапии статинами. Мы вновь получили анализы разных, не только фармацевтических компаний, вы знаете о анализе Блумберга в отношении NTT, при использовании статинов. Мне кажется, что это положительный момент. Если говорить об использовании эзотимиба при лечении пациента высокого риска, то моя позиция личная, то это в основном комбинированная терапия у пациентов, которые уже получают статины в соответствии с Improved Trial, вы знаете, в отношении пациентов с профилактики осложнений пациентов с острым коронарным синдромом, и пациентов, где высокие дозы статина приводят к побочным эффектам. Поэтому это вот такая позиция.
Евгений Владимирович, к этому примыкает один из вопросов, который был задан в отношении фибратов и их роли на сегодняшний день, возможно, сохранившейся, а возможно нет, в первичной профилактике.
Ну, это в основном пациенты с гипертриглицеридемией, с сахарным диабетом. Вот эта ниша, где фибраты могут иметь значение. И я не настолько, в общем, негативен в отношении исследований Field, который был выполнен. Мне кажется, что там много было очень интересного. И я почти уверен, что мы еще вернемся к роли фибратов в лечении пациентов высокого риска с гипертриглицеридемией и диабетом.
Коллеги, пожалуйста, еще вопросы из зала. Есть возможность и время. Тогда вопрос из сети. Очень актуальный с моей точки зрения, хотя простой. Какова должна быть длительность терапии статинами при первичной профилактике, в том числе при достижении целевых уровней?
So, I think simple question,
Very
simple
but
answer.
Still, well, often asked, I should say.
Indefinite. It's a lifelong treatment that we're talking about if it started.
And that's why it's so important to actually have that risk discussion that we talked about, that this is a lifelong therapy. So the discussion has to happen the first time it started, so the patient can understand that they'll have to take it long term and they are going to derive a benefit. So we have to make sure that it's a patient who actually will derive a benefit from therapy, and the patient has to understand why they are taking it.
I think in the interest of time, we may have to have just one more question, and then we'll ask Professor Schlachto for some closing remarks. Thank you all so much. One more question?
Поскольку у нас время действительно уже остается немного, я еще раз обещаю от имени организаторов, от имени Российского кардиологического общества, что на все вопросы мы ответим всем, кто их задавал. Первый вопрос, который поступил по поводу первого доклада, он поступил, кстати сказать, на английском языке. А какую шкалу все-таки предпочесть? Он довольно хитрый вопрос. Score или шкалу ACC-AHA, ACS-CVD? What's preferable, according to your personal opinion?
So I would say that you have to use the risk algorithm that is used in population that's similar to the population that you're dealing with. I would say that because of the context in which the risk score is being used in Russia, I would probably go with SCORE. And the reason for that is that they actually have made this chart which, differentiates between countries of low versus high incidence of cardiovascular disease. So it's okay to use SCORE. I'm not recommending that you use ACC-AHA risk algorithm. What we are recommending here is that you use something. Don't just say that this is high risk, this is low risk, this is moderate risk. Use something and understand what you're calculating. So as long as you use SCORE on the correct patient, you understand that what you're calculating is fatal cardiovascular events. You're not going to be looking at non-fatal MI or non-fatal stroke. And as long as you're discussing that with your patient and trying to elicit their preferences, you are not going to go wrong. That's all I would say.
Если можно, я тоже поучаствую в ответе на этот вопрос. Мне представляется, что использовать нужно ту шкалу, которая в большей степени отражает характер распределения факторов риска в той или иной стране. Если говорить о шкале SCORE, то мы участвовали в создании этой шкалы, и российская популяция тоже представлена в целом в этой шкале, поэтому вот с этой точки зрения, мне кажется, что нам более правильно использовать именно эту шкалу. Если бы мы имели данные относительно распределения факторов риска в России с применением других шкал, то можно было обсуждать этот вопрос.
And we do know that Russians and Americans are very different. So the ACC-AHA risk calculator was calculated in, was derived from American population. So it's obviously not as relevant to a Russian population.
Well, I hate to break up the party, but I think since it's almost 7:30, I'd like to go ahead and ask Professor Schlachto to make some closing remarks, and then I'll do a few housekeeping remarks afterwards.
Дорогие друзья, коллеги, я очень вам благодарен за уникальную возможность проведения этого первого вебинара по проблемам атеросклероза в Российской Федерации. Это очень важный, мне кажется, шаг в развитии взаимоотношений ACC и Российского кардиологического общества. Я не сомневаюсь, что у нас будут другие вебинары. У нас ежегодно проводятся совместные симпозиумы на наших мероприятиях. И я очень благодарен докладчикам, моему соведущему, доктор Моррис. Я, безусловно, должен от всех от нас, наверное, поблагодарить компанию Pfizer, которая способствовала тому, чтобы этот вебинар состоялся. Поэтому спасибо всем. И я думаю, что у нас сегодня был действительно успешный опыт первый, который, мне кажется, в дальнейшем будет только развиваться. Спасибо.
Просто несколько заключительных замечаний. Прежде всего, спасибо вам всем, спасибо сопредседателю господину профессору Шляхто за прекрасное ведение конференции.
That will be important for you in order to get webinar certificate for your continuing medical education credit there. Those of you who are joining us online, there will be a link for you there on your web page, so please be sure to do your post-assessment as well. A reminder that the next webinar on secondary prevention will be in May, so we will hope to see all of you there, including those of you who joined us by YouTube. And again, we thank all of you so much for the honor of being here with you and for your participation. Thank you so much.
Глубоко уважаемые коллеги, пожалуйста, не забудьте сдать пульты для голосования и наушники для синхронного перевода организаторам. Thank you very much. It was a pleasure, and excuse me for foolish questions. They are really very relevant. For how long? This is what the doctor is asked every day. He's doomed to tell all your life.
Thank you very much. No, it's not easy. Yes, but necessary. Thank you very much. Thank you, Professor.